I would now like to invite Professor Alan Lebrick, Director of M Health Initiative, Johns Hopkins University, Baltimore. And he is the founding director of the Johns Hopkins University Global M Health Initiative, a multidisciplinary consortium of 130 projects engaged in M Health innovation and research across the Johns Hopkins system, an infectious diseases epidemiologist. We look forward to his presentation of his experiences on leveraging mobile technology to reach the last mile and improve health for all. Professor Allen, please.
Thank you very much. Can I check the mic? Yep. So I'm going to come away from the podium because I think it's better to engage with my audience, and with apologies to those of you behind me, I'm not turning my back on you intentionally, so I beg your forgiveness. So, mere Gujarati sari neti. So, আমি বাংলাতে আপনাদের অনেক ধন্যবাদ জানিয়ে শুরু করি because my Indian language is Bengali. My mother is from West Bengal, so ওইটা দিয়ে আমি শুরু করি আপনাদের সবাই শুভেচ্ছা আর ধন্যবাদ. So it's always nice because people think, oh, there's some foreigners on the stage, but actually I feel very much Indian, and it's my real pride to be here today. So thank you all of you for having me here. Despite my name not being very Indian, I can tell you that Make in India, I'm partially made with parts from India. So the quality control is certainly there. So I was trained as an infectious disease epidemiologist, and as an infectious disease doctor, here is how we are trained to see the world. Where, as my colleague Louis Georges from UNICEF described, the countries of the world here have been inflated based on the relative proportion of burden of death and disability that those countries experience. So you can see why we spend so much time focusing on India and sub-Saharan Africa as our countries of focus, to bring the situation of global health to a better place. When people ask me why, as an infectious disease doctor, is talking about technology, for me it's a very simple slide. This is the slide I wake up to every morning, because it reminds me why we need to find new ways to deliver public health innovations throughout the globe. Despite the many innovations and improvements we've made in global health, we still are experiencing on a daily basis, one Boeing 747 filled with new mothers and pregnant women crashing every single day. Not to mention, in the case of neonates, we're looking at 4 to 5 Boeings. So the need for us to act now, and I really applaud Honorable Minister and Secretary for bringing that to bear, that the urgency of action is really at the forefront. How do we get our frontline health workers to be able to deliver the highest quality of care, even when their level of training may not be adequate for the level of services we'd like to provide? How do we task shift some of those protocols to rural areas where they can be delivered to women who cannot access facilities? How do we overcome the challenges of reaching the most remote areas of places like India and Bangladesh and Nepal, where people are removed from the facilities that function so well by geographic or even economic obstacles? In places where we work, rural parts of India, rural parts of Bangladesh, pregnancy is something that is almost done in isolation. Women experience that period of time in their lives isolated from care, often receiving little to no antenatal care in many parts of the globe. In India, the situation is improving quite dramatically. The statistics of facility-based deliveries from Gujarat are phenomenally impressive and something to model across the rest of the world. This is what we want to see. We want to see a future where every family has access to information. Basic things that we who live on the more sophisticated sides of the country have taken for granted. Where they have access to services and medicine, where every health worker has the training and skills to do their job well and consistently. But we also need a health system that counts and is accountable for every life. And that I will just pause for a second, because we talk a lot about accountability in health systems. But at the heart of the word accountability is the word count. And when we continue to estimate the number of maternal deaths, the number of neonatal deaths, we do ourselves an injustice because we are saying that not every mother is worth counting, and we have to change that across India and across rural South Asia. But there has been a sea change happening behind the scenes in public health, and that's what you see here on this slide. 6.8 billion mobile phone subscriptions in the world today. So that's the same number of mobile phone connections as there are human beings on this planet. The health system has done little to nothing to make this happen. It's an opportunity that has been given to us on a silver platter that we now have to mobilize and take action and leverage to our benefit. The world is rapidly changing. And you saw that map I showed you a few minutes ago with the inflated boundaries. Here's another map of the world. There are no political boundaries on this map. But yet, 10% of Facebook connections, only 10% of them are shown on this graph, because otherwise you wouldn't even be able to see anything. This is in 2011, and this is in 2014. So Facebook is the tip of the iceberg, because it's a sophisticated technology. It's not SMS. So if this is happening with Facebook, imagine what's happening with a simple technology like SMS. And it brings us to this issue that we're talking about today with innovation and technology for health, the role of this new thing we call mHealth. Recently with UNICEF, we published a statement that helped to describe what is mHealth, to describe a common language across the ecosystem of people who are doing innovative work using mobile phones to improve and strengthen health systems. Now, what this document did is really describe the fact that there is no such thing as mHealth. When someone in the audience says, oh, I'm doing mHealth, and you say, I'm doing mHealth as well, you may be doing two very different things. And it's important to make that distinction so that we can talk to each other better. It doesn't make any sense if we're talking past one another. So mHealth can be used for education and awareness. mHealth can be used to manage supply chains. It can be used for health worker training or outbreak monitoring. And so we have to recognize that there's a diversity of flavors of mHealth. And I think that's critical in how we measure whether our mHealth is working, because that's not the right question. As my colleagues from UNICEF just pointed out, there's so many different ideas and innovations happening, we have to be able to measure them to identify what's working. Our colleague from WHO also talked about health systems. And if universal health coverage is our goal, we want to reach this red line at the end of the bar. And I apologize if the slide is not absolutely clear. But in order to reach universal health coverage, we need to know who it is we are reaching. Again, coming back to that foundational element of the denominator. We need to be able to enumerate and count the women of reproductive age. We need to be able to count the newborn infants who deserve to be vaccinated. Then, on top of that, you can work on things like supply. Are the supplies available and accessible? Demand. Do the clients come in when it's time to receive a vaccine or to receive anti-malarial drugs? And are those goods and services at the quality that every one of you in this room would insist on when you went to the doctor's office to receive a treatment or a drug? And at the very end of it, we must not neglect the financial aspect of this. Are these services and drugs affordable? And that's another space where the intersection of mHealth and mobile money is becoming very, very exciting. Across Eastern Africa, UNICEF and other groups have leveraged the fact that mobile transactions are happening every day increasingly to motivate community health workers. Imagine if I do an ANC checkup on a pregnant woman, and within 5 minutes of doing that checkup, I receive my payment for having done that work. And I get a bonus when that client reports that the quality of service that she delivered was at an exceptional level. So real-time incentives through financial reward is something new that we never could have thought of before. And of course, we have technical issues when we're trying to do a talk on technology. But mHealth is very basically about 5 things. Collecting data, faster, smarter, cheaper. Counting events, births and deaths. Connecting individuals. How many of you leave your phone at home when you go to the office. And you feel naked because all day you wonder, who's trying to reach me? And where did I leave my phone? And it's that connection that we have now constantly. My wife can reach me at any time. I don't know if that's a good thing or a bad thing, but you know, that's certainly something that we miss because of that connection that we now have with mobile phones. Clinical medicine and public health is about compressing time. Whether you're a cardiologist or an endocrinologist or a cancer specialist, you know that what we try to do is reduce the time between diagnosis and treatment, between disease and that end event that we're trying to prevent. We need to compress how much time we allow to go by before we take action. When a newborn is delivered, whether in a rural facility or at the home, we only have a narrow window of opportunity to act to avert neonatal mortality. So if we don't have the ability to compress time and to open these new windows, we can't imagine reducing neonatal mortality across a vast nation like India. When a birth occurs in parts of sub-Saharan Africa, it's often days or weeks go by before the health system is aware that that baby is born, leaving the window wide open and uncovered for appropriate clinical action to be taken. But it's also important to think about systems, and everyone on the panel this morning has mentioned the issue of systems thinking. We can't focus just on the technology. The mHealth exists within a broader ecosystem of solutions, functional facilities, the availability of assets to pay for services, the availability of transportation. And I think one of the points that we will increasingly have to come to terms with is how do we use that data? Because this digital data is not trapped in a ledger under a table in some rural facility. It's now digital data that we can harness and decrypt and analyze and understand what's going on in our facilities across this nation. With WHO 2 years ago, we formulated the mHealth Technical Evidence Review Group, an agency to give support to governments across the world, including we are working with now 10 different governments in sub-Saharan Africa, and we hope to work more intensively with the government of India to look at the evidence, because for 2 decades now, we've all been indoctrinated to use evidence in our decision making, to look at what works. There are these new boards called Health Technology Assessment Boards, who are going to require us to review the cost effectiveness of innovative technologies before, as a government, we invest in those technologies. So the role of the MTurg is going to be to provide that guidance in terms of where is the adequate evidence in this space. So as we think about mHealth, there are really 3 strata which we need to be thinking about. mHealth that improves patient knowledge, so mHealth that targets the population, mHealth that improves provider competency, so mHealth tools that give providers the protocols which they need to follow, and finally mHealth tools that strengthen the health system, which improve supply chain management, monitoring of staff in remote rural areas. I had one minister of health from a SARC country tell me, you know, the price of a tablet is now $80. And I'm paying $80 a month for my CHW in the field. If this tablet can tell me that that worker is not showing up to her a post in the morning, then it's paid for that $80 right then and there, because I know that she's not doing the job that she's supposed to. We have solutions of known efficacy. As my colleagues referred to earlier, we have books that are inches thick that tell us this, and this works to reduce neonatal mortality. So the challenge for us isn't not necessarily knowing how do we prevent neonatal deaths, it's getting those interventions of known efficacy to reach high levels of effective coverage. And in that process, as you've just mentioned so nicely, Mr. Chabra, is we run into these challenges, failure to follow guidelines, drug or supply stockouts. We run into the issues of lack of performance tracking. And that's where the mHealth opportunity lies, if we harness it, to bridge these potholes in that highway to effective coverage. So the question for us is not so much, does mHealth work? It's how can we leverage mHealth to optimize what we know works? And I think that's the bottom line of what you need to take away from this. To give you a quick landscape, mHealth There are tens of thousands of mHealth projects around the world. We have the example of Mama, and that's been used now several times today as services that send pregnant women messages that are appropriate to their gestational age. This has now been scaled up nationally in the country of South Africa. And they are using this opportunity to register pregnant women into the health system, to give them an ID and then give them text messages during their pregnancy. SMS for Life is being used by Novartis and other companies across sub-Saharan Africa to help track stock levels. So if there's an impending stock out, there's a replenishment of that stock before we run out of drugs in a clinic and a child comes in with malaria and we have nothing to treat them with. Rapid Pro, Frontline SMS, there's a number of softwares that are now available. And those of you who are students or innovators in the room, you can go and take this off the shelf and use it for free to develop a system that sends these text message reminders. I know I'm a very bad patient. Every time I'm given a bottle of tablets to take, 50% of those tablets will be taken late or on the wrong time of day. But now there are many studies that have shown by sending a simple SMS to a patient 2 times a day if they're supposed to take their drug, improves adherence to drugs dramatically. So that's a real opportunity for us to use mHealth. And as I mentioned, this is something that any of you can do, just taking it off the shelf and using. We mentioned already this mobile Kunji, which is getting worldwide acclaim as a way of standardizing the way frontline health workers deliver health information to their clients. The Mobile Academy, another fantastic invention that has come out of India and that is inspiring people around the world. Another project that Stanford University has worked in India to develop, the scanning of the buccal surface to look for precancerous lesions. As we know, the chewing of pan and other tobacco-containing substances leads to oral cancer. And so to task shift that complicated strategy to frontline health workers who can use the camera on a smartphone to take photographs and identify those most in need of services for referral. Microsoft is doing some exciting stuff with fingerprints and TB adherence here in Delhi. In Uganda, U-Report, citizen reporting of when facilities are ill-staffed or ill-supplied has been a phenomenally interesting project. And this is also driven by UNICEF. So we have projects and examples around the world, including here in the state of Gujarat, such as eMamta, that have shown the potential of e-health and mHealth to improve health systems. We know that pregnancy registration can itself be a major part of preventing maternal and neonatal mortality. Because when we register, we know who to give services to. We mentioned system efficiency. One of our colleagues had just said that our health workers spend an inordinate amount of time doing useless paperwork. In one study we just completed in Bangladesh, we found that the frontline health worker completes 19 ledgers. 19 ledgers in a daily basis, 473 fields. Do you know how many of those fields are unique? Only 60. So that's 413 excessive fields that they're spending time filling out when they could be seeing mothers and children using these systems. So I was so inspired to hear from both our Honorable Secretary and Minister that we can make significant movement forward if we have that political will to change these systems. With WHO, we're building an open source system that incorporates the lessons learned from eMamta and others around the world called Open Smart Register, which allows frontline health workers to digitize those ledgers so they don't have to carry around 20 kilograms of paper, but instead can have this be displayed to them in a smart way that they can see which women need attention the most urgently. It can allow those health workers to show video for IEC and other kinds of counseling. In Bangladesh, we've helped to attack the inefficiencies in the vaccination system. And this is something that we're hoping to work with the government of Gujarat to implement here as well to improve the vaccine delivery. mCare, a systematic approach that includes the patient as part of that digital health innovation. Because mothers in mCare, now currently in force in Bangladesh, allows the pregnant woman or her family to send a text message when she's going into labor. So now we can actually act on that window of opportunity around the perinatal period. A preliminary result that I'm just now sharing with you for the first time is that we have seen a 3-fold increase in antenatal care utilization simply by this two-pronged approach. Reminders to the mother, reminders to the health worker that this mother needs an ANC visit in the next week. There are new point-of-care diagnostics that are coming on board. You see here a portable ultrasound, a portable microscope. Within the next 5 years, these will be available to us to harness in our rural populations. How many of you have seen this technology? It's called a micro SD card. A size of your thumbnail can now hold the information content of 600 DVDs. So in rural India and Bangladesh, people are using these to watch Bollywood movies. Why not install health videos and information on these to allow them to access a library of video training about health information? I have in my pocket one of these devices, an FDA-approved EKG device that allows you to take an EKG in a village or at the clinic without all the leads that we have to work with as clinicians. So I'll just move through a few slides, but we can see the potential with even the private sector getting involved. I know our colleagues at Apollo and across India are developing these kinds of hotlines where you can register and become a continuous patient with a service that provides you the kind of telemedicine that we were talking about, going to scale and not just stopping at a pilot or a conceptual level. But we have concerns, and we have to be cautious, both as innovators and as academics, about technical stability, reliability, the user competence. Is the system designed with the user? Or have we sat in a boardroom and designed the system in a vacuum? That's very, very important. We worry about theft and electricity, but in many places, solar panels have overcome this issue. And we have to understand, as my colleague has pointed out to me yesterday, that just moving from data to information is not sufficient. We need to go to knowledge and wisdom so that we're actually using that data for better practices in the future in how we deliver healthcare. There are places where you can go to learn more about mHealth. I'll just mention mhealthevidence.org, mhealthknowledge.org. These are two websites that were set up by USAID to serve as a compendium of knowledge in this space. mRegistry is a registry of projects, so if you are an mHealth innovator, please go to mRegistry. It's a WHO-maintained site where you can document what you're doing in this space. But there are a number of areas where mHealth has the potential to improve how we deliver care, both in high and low resource settings. And this will be available to you to refer to later, so I'm not going to read through these. But across patient, provider, and health system layers, there is the potential for mHealth to transform how we deliver care. I'll take a moment to make a few remarks on how important the role of government is here. Because we often ask, how do we solve this issue of thousands of mHealth ideas not talking to each other? And where government comes in is in providing that central leadership and guidance, starting with an integrative policy and a committed budget that supports that e-health or mHealth policy. Defining standards for the innovative community to say, if we are building a new solution, here are the standards which we need to follow. Defining priority areas. It is up to the government to say, these are the areas which we want to prioritize the innovations to come from. But also providing a forum for these innovators to collaborate, for them to talk to one another in a shared space is something that the government has done in places like South Africa and Kenya, as well as in South Asia. And then finally, providing business models for the private sector to be engaged in this innovation. It's not always obvious what the business model is to innovate for the bottom of the pyramid. But as many of the speakers, including our colleague from WHO mentioned, there is a massive base of the pyramid here in India. We cannot ignore them as we move forward into outer space and to Mars. They have to come with us as we progress and move forward. There are many opportunities for collaboration, and I hope over the next day or so, I'll be able to explore these with my colleagues on the panel as well as with the ministry as time goes by. But I would like to suggest that we strive for this other program that we can make happen, starting with Gujarat, where we count every life because every life counts. And I think that would be a phenomenal initiative to undertake and lead the nation forward as we talk more and more about CRVS in this community. We must start simple, leverage mHealth in its natural state, understand how citizens are using mobile phones, and let ourselves be inspired by that. And don't underestimate the power of a phone as a phone, because we often get lost in the gadgetry, and that's not the main message here. We must not go from this. And I apologize for those of you who haven't seen this kind of situation, but in parts of India where I have worked for many years, this is the state of health information systems. But if we go from this to this, we will not be making progress. So more data is not better information. So we must be careful as we move forward to be sure that we're collecting what we need to collect, not just what we can collect. And I've been really inspired over the past day by this picture that I've seen several times of our Honorable Prime Minister taking action in his own hands. And I think we cannot stand by and continue to let mothers and babies die when those deaths can be counted and averted. So as our Gandhiji has said, you may never know the results of your action, but that should not stop you from moving forward. If you do nothing, there will be no result. And with that, I'd like to thank you very much. Bahu bahu shukriya. And I appreciate all the time.
Thank you, Professor Lebrick. That was an extremely informative session on mHealth. And with the mobile phone becoming an appendage or part of an organ of the body as the days to come. And we hope to see many technologies which are linked to the mobile phone. I would now like to invite Professor Pranab Kumar Datta, Head of Medical Science and Technology, Indian Institute of Technology, Kharagpur. Professor Datta is an electrical engineer by training, and his principal research interests include image processing and machine learning, including biomedical image processing. And now I would like to request Professor Datta to make his presentation and share his experience on the use of technology. Professor Datta.
Good afternoon, everybody. I am feeling proud, privileged to be here, first time in vibrant Gujarat. And I am coming to Gujarat after 15 years, so I see the change. Okay. So, and also, today happens to be the birthday of Swami Vivekananda, and I am speaking at the place of great innovator in political struggle, Mahatma Gandhiji, who invented Satyagraha and taught the world. So today, of course, I will be talking a little bit different. It is about point of care technology and some bit of with some examples that we are doing at IIT Kharagpur. So when we talk about healthcare, it of course depends on many things. First of all, it depends on economy and infrastructure. It depends as well as science, technology, and society, because the innovation is a connection between the mind, material, and action. And then society plays a big role. Society plays a big role, individual plays a big role, and also the rules and regulation plays a big role. So one can say that innovation occurs in the mind, in a person's mind, but it can come to action when in a particular place. The place needs to be prepared. It can only occur in a prepared mind, and it can be acted upon at a prepared place. So therefore, the policy, regulation, and management is a big factor to implement for deployment of such actions and innovations. It has to be, innovation need to be in such a way that we cannot sacrifice quality, because when we talk about low cost, many a time we compromise with the quality, because we know simple rule that you have to leave something and to gain something, okay? So in that, we leave little bit of quality at the cost gaining the price. So now, innovation should come in such a way that basically we can gain more at that same price. So my next few slides will be about some of the things that we are doing at IIT Kharagpur before going to few more slides about what can be done and what we shall do. Now, at IIT Kharagpur, actually, we have formed a school of medical science and technology, which is an interdisciplinary school, which many people may not know, so that's why this slide. This is a conglomerate of engineers, scientists, and doctors. So both, all three are there are the faculty members of our school. And we are thinking little big just now. We are planning a 450-bedded research hospital, and which will be integrated in the rural background of Kharagpur. And we hope to outreach to the surrounding villages, which we have already started. So we have some examples that I want to show that what particular use of technology can be. This is about some optical scanning technology, like optical coherence tomography. Now in rural Bengal, often we see that chronic wounds that does not heal. So time and again, we have to examine it, the doctors need to examine it. Now taking biopsy of such chronic wounds is painful. The chronic wounds are devastating to the family, friends, many people. So now if some non-invasive technique can be used, so we have this optical scanning technology, which has been compared with, say, other gold standards, the taking biopsy and analyzing. So that can give us a point of care technology which can reduce this biopsy, number of biopsy, which can reduce the visit to specialty care hospital. This optical point of care technology can be there at a digital kiosk at a village, where it can be handled by, say, some not a fully knowledgeable doctors. Okay, so I will skip this. It's the same thing we have done also for retinopathy, with little bit of knowledge of image pricing and applied to it. It can enrich, given enriched informations, and which can be transmitted to the specialist and can reduce the number of visits. Because reduction of number of visits, which one of our primary concerns were, like in Eastern India, the number of specialty centers are less, they are costly, and the visits not only cost about the medicines, it's about the other cost that associated with it. So therefore, that one of the things which we had targeted to develop certain point of care devices that can be integrated into digital health. Then we also do other kind of research like bone tissue engineering, scaffolds, etc., implants. And this is about one of the technology that is quite innovative. It is in third phase of clinical trial, but because it's a little bit counterintuitive, so therefore it took long time for Professor S.K. Guha. Since last 24 years, he is trying this male contraceptive to be deployed. It is being manufactured. It has been accepted by developed and developing countries and some states in India, not fully in India. this is Risuk reversible male contraceptive device that is also a kind of device that can do maybe it can change some family planning scenario. We are also want to say screening, because screening plays a big role in rural India, and we are in a rural background, and in rural Bengal, one of the disease that is prevalent still now is malaria. So malaria screening and helping the expert doctors with screening the slides and highlighting that which part they need to concentrate. So that gives, that provides a lot of patients enough scope to consult to the experts. Now, there are of course other technology like diagnostic devices, and there is another technology that currently clinical trial is going on with National Orthopedic Hospital is for hemiplegia patients. So that is about correcting foot drop and hand gripping for partially paralyzed patients. So such kind of deployment, we found that it require day-to-day actions, because we need to track the patients. So therefore, we need to have an information system along all such devices, especially for when we do such kind of trials. We face the problem of tracking the patients. They need to visit, say, every month, but then some patients are missing. So we have to track them, and that can be done as efficiently in today's mobile technology and some of the technology that my previous speakers that has explained and so nicely. So thanks to Professor Allen and the other speakers for exposing that technology. I think that will be very much helpful. But there are some big challenges. Big challenges is that if we talk about new drug and a new device, the lead time is too much. It's about 10 to 15 years if we want to, and also high investment. If we want to introduce a completely new drug or completely new invasive device. For non-invasive device, it is a little bit simpler, rules are a little bit simpler. And for India, actually, there is no clear-cut policy between drugs and devices. So therefore, that's a problem. So that, I think, new draft policy and other things will take care some such things. And also, that will reduce the translational time. Translation of, say, from bed to bench and bench to bed. That way the innovation will occur. So the inventors must learn from the clinicians. So it has to go from bed to bench, and then it can come from bench to bed. It cannot just come from laboratory to the clinicians. That one-way traffic is not that much meaningful. Now, in healthcare delivery, fortunately, especially in mobile and information IT-related healthcare delivery, the lead time is a little less. It can be as low as 1 year, but generally, on average, it is 3 to 5 years, and investment is less. But we can do a lot for managing distribution system, for improving distribution system. If we focus on innovation in healthcare delivery, especially for India and Asian countries, because that will give us a leapfrog kind of thing for utilizations of the technology that is already available. And success rate, I have not written there, because success rate for new drug and new devices are very, very low. So it cannot be written even that it is that low. So now it is not so for ICT, and that is one of the good thing and things of hope that that we can utilize. As I have told, that it requires active support and a political will to get to nurture this in our environment. And for healthcare delivery, if we want to have an information system deployment has to be distributed, but it needs to be connected. It has also to be connected. Unless they are connected and centrally available and also locally available, that does not have any meaning. So point of care devices, one we are specializing, that has to be integrated with digital kiosk, which should be biometric registers, and preferably with today's Aadhaar card or any other kind of technology. And in digital kiosk, the informations, as my previous speaker has already pointed out, that information need to be compressed. Now, this compression need to be targeted. Now, this targeting is very important. Targeting need to be done based on the device and based on the people who are using it. It need to be indicative when, say, we are using rough point of care devices with paramedics. It can be qualitative in the next stage. It can be diagnostics. Okay, so that means when you are associating with a specialist, and so the information domain and their inference needs to be hierarchically structured. Otherwise, there will be information pollution. What is in most of the cases it happens, and also this information needs to be utilized. Firstly, for preventive immunization, nutrition, and lifestyle support system, and it has to be. It can be also used as diagnostic. It has to be done in a regular fashions. Unless it is distributed and the healthcare is available in a at a short distance, we cannot make these regular visits possible. So that is the distributed delivery model we must come up with. And that the help of the mobile applications and other kind of point of care devices need to be taken care, used for this purpose. So therefore, I would request everybody to come forward with their domain of knowledge and to make this venture successful. And thanks to the organizers for organizing such a seminar, which will be very useful for everybody, for the developers, for the users, and for the policymakers. Thank you. Thank you.
Thank you, Professor Datta, for sharing your thoughts and your experiences. May I now invite Ms. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Enterprise Limited, and sharing her vast experience on transforming healthcare with the use of technology. Ms. Sangeeta Reddy, please.
Honorable Minister of Health of the vibrant state of Gujarat, Shri Patel ji, our Chief Secretary, other dignitaries on the dais, and healthcare evangelists and people who are really making a difference in your own individual way in healthcare, all of you in the audience. Namaste and thank you. It's a great, great pleasure to be here to share a few thoughts and ideas. I do realize that I am standing between you and lunch. I also realize that after a tremendous background from everything we've heard from the ministers and the policymakers who gave us the hope that yes, we can do it in India, to the international perspectives of what's happening in the world, to the science perspectives of what science can do, I stand here to share a few inputs on what healthcare providers can do and are doing. And I really want to begin by saying that there's a lot happening in India, as has been acknowledged. We need a few more things to connect the many dots, because India is, on the healthcare scenario, islands of excellence in an ocean of inadequacy. There is so much that needs to be done. And yet there are these islands that have deciphered what to do, how to do. And there is now the technology which is connecting these. And as the wonderful state of Gujarat described their healthcare vision with the 3 A's, which is accessible, affordable, and accountable healthcare, a very important word. And my colleague gave you the 5 C's of mHealth. I actually want to share with you my favorite, which are the 3 B's. And these 3 B's, I think, are what is transforming healthcare. The healthcare you see today is not going to be the healthcare you see when you are retired. Is not going to be the healthcare that your children use, and definitely not the healthcare of your grandchildren. The first B is really biology. With the Human Genome Project, when the DNA was deciphered, we began the journey to discovery of why does one person who eats more jalebis than me not become fat, and why does the other person who eats just half a jalebi put on weight? Why does somebody who exercises and doesn't smoke get a heart attack? And why does somebody else's grandchild have this terrible hereditary disease? The biology is showing us those secrets. And with that, we are able to cure better and faster, be predictive, do the analytics, and therefore stay healthier, live longer, and prevent not just the disease and the expense of the disease, but the sadness and the burden and the suffering of the disease. So that is biology. The second big one is really bytes. Moore's law said that the computing capacity, the bytes that we have in our computer, my mother used to work in IBM 45 years ago. The size of this room was the computer which had less computing power than my phone. Bytes, the power of processing has increased. Because of that increased power, we can see more, do more, analyze more, connect more. Our CT scans are better, our PET CTs are connecting to our MRIs, and therefore, science and medicine has become, before it used to be, high touch. He would feel your pulse, your beautiful GP would feel your pulse and tell you what's wrong. Today they're looking at high tech, hundreds of images. Healthcare has become about information technology. And therefore it's the processing capacity, but the third B is actually the most crucial one, because in a country like India, we're saying please connect, and that is bandwidth. And when our Honorable Prime Minister said, Digital India, every corner will be connected, the whole country will be Wi-Fi, and everyone will have a digital identity or a space on the cloud. It transformed the possibilities of what we can talk about. So let me begin by saying the healthcare we have today, the healthcare we're visioning for in the immediate tomorrow, is not going to be the healthcare that our children have. And so let's move towards this better world quicker, faster, and in the most innovative manner that we can. I want to quickly play a little bit of this thing. My colleague referred to you about the ECG machine and the sensors. We have it right here in India, accessible today, under 3,000 rupees. You put on the button, an ordinary phone. When this came to me from Vinod Khosla, it was available only for the iPhone. And I told him, please Vinod, 45% of the upper class of India uses iPhone, but 85% of this country is on Android. So they took that and made this small little pocket. So you put this onto your Android phone, put this on, put the 3 fingers on each side, and I will give you an ECG in 3.5 minutes, and I can personally demo it after this. So what I'm trying to say is that the technology we're talking about all over the world is here in India today. So let me quickly, as quick as I can, and I'll go really brief on these slides, talk very briefly about what we do in Apollo, a few solutions that we have, and hopefully our vision to connect. Because when Nadaji said something, our Honorable Minister said something superb, which was, telemedicine used to be one-to-one. Our vision, next vision for telemedicine, and we started telemedicine 15 years ago in the village where my father was born. We connected that village with all the doctors in Apollo, and they would walk into the telemedicine room, leave their office and go there because Chairman Saab ka gaon hai, so they used to go and see. But then it became better and better. We moved that into their office. Then we moved it into their home. And now we're doing many-to-many telemedicine. We then had like 250 telemedicine stations, 100 of them in Africa. Today, via the internet, many to many, any given minute, an Apollo doctor is connecting with some member of public, and we do over 3,000 teleconsults per day. So the whole world of telemedicine has changed, but what is important is what I'll also show you again here. So let me really jump into these slides. My team has taken some trouble, so I must share with you the pretty slides they made. Apollo Hospitals today, we are over 9,000 beds, among the largest healthcare provider in the world. But the important thing is really that it's not just hospitals. We have the large super specialty hospitals. We're privileged to be in Gujarat, but we have hospitals in villages, 150 bed ones. REACH is our rural equitable access to quality healthcare model, which is lower cost but the same quality. We do bypass surgery for under $3,000. For 1.2 lakhs, you will see bypass surgery, but one thing, there is no compromise and no change, and that's on the results. 99.7% success rate. And this is replicated across renal transplants, etc. So our healthcare is in the 3 tiers. That is high-end, super specialty, tertiary healthcare in urban as well as in rural. It's secondary healthcare and specialty formats, and it's in the clinics. And because we looked at this, we needed to connect these. So we have a technology company and an aspect, we have an education and the university, we have health insurance because we believed people need the access. And therefore, Apollo is no longer just the hospitals. And because we have this connected environment and a large volume of patients, we have served or had the privilege to serve over 33 million lives from over 120 countries, have completed over 130,000 heart surgeries, did the first multi-organ transplant, the largest series of solid organ transplants in the world. We are the busiest solid organ transplant in the program in the world. So this gives us an insight into healthcare that we hope we can share. And every day is a busy day, and only technology can help us do that better. So just moving on, the current situation really in India is a situation with challenges, and I won't go through it. You know the numbers, the bed shortage, the IMR, the MMR, the problems that we have with lack of doctors, lack of nurses, but it's also a beautiful opportunity to transform what we have, and states like Gujarat are really showing the way. Kerala has some wonderful health indices. Tamil Nadu has done some work, but many others are trying to catch up. And nurses from not only Kerala, but the northeastern states are today beginning to serve the world. So these are the opportunities we have to transform, to serve. Technology and devices will play a major role. Mobile phone will play a major role. Preventive healthcare and the prevention of NCD-related disease. So while on one hand we talk about IMR and MMR, we must in the same breath begin to talk about NCDs, because as a country, as our GDP grows, and in my opening slide I showed the development and the beautiful bridges we're building, but also an ECG like a mobile phone, because we need to make sure that the heartbeat of India is not only about GDP, but about our health indices. And if we can start tracking health and happiness, then our GDP will grow automatically. So I just want to say that this is an opportunity to transform. But the big question is really, how do we reach out and make quality healthcare accessible and affordable to all? In a situation today where we are the 5th largest consumer market, 600 million middle class who want, afford and seek healthcare, but actually 1.2 billion people who deserve healthcare. And a number of areas where there is an opportunity to do something much, much better. And 12% of the population today with absolutely no access to healthcare, an increase in the NCDs. It is estimated by WHO that India will spend $6 trillion, not billion, $6 trillion by the year 2025 because of the impact of NCDs. Yet we see other countries where they brought down the burden of NCDs by 16%. So there is a lot of opportunity for us to transform. Again, like I said, I'm going very quickly, but I do want to put down one fact, and that is we are one India, but we are actually multiple Indias. We have different challenges, and the 85 million people of the population who live in urban areas, who are consuming 400,000 devices and who all the multinationals are coming to serve, have a very different problem from the lower segment, which is the 740 million of our population who have only 50,000 doctors available to treat them. So there's a huge difference in the healthcare. We need to think of something which is a framework which encompasses this entire population, and that's really what I'm trying to do. But the first point I want to make is that it's not just that our infrastructure is changing, and thanks to God and the Honorable Prime Minister, our cleanliness level is changing, but the changing landscape is also happening because the patients are different. The psychology of people are different. My driver's daughter is qualifying and going to become a doctor tomorrow. Our people want more. They want it for themselves, they want it for their children. Today we see an empowered patient who's asking more information. Doctors are saying what to do, they're all reading internet and Google and asking so many questions. It is an empowered patient, a patient empowered by knowledge. It's a decisive patient. They want to buy. And we have a wrong divide between the private and the public sector. But public know exactly how to do. They'll go to a small GP, they'll get this prescription, they'll go to the dispensing pharmacy in the government sector, they'll get the medicines free. When they need a diagnostics test, they'll go to a private provider and get diagnostics, and when they have a major problem, they'll come to Apollo Hospital. They know the whole story. So this device, this decisive patient is understanding what to do, and we must work with this, because the government is today saying he will be an entitled patient. I want to give universal health care is one of the most beautiful proclamations which has been made in India. We must find ways to enable that, where we begin to work together. This patient is also not only empowered, decisive, entitled, but he's a demanding patient. And therefore, we need to find ways to use innovation and technology to bring down costs and make quality affordable. This I thought was important to really share. The mindset of the patient is what decides how you deliver healthcare. And that's important. They are no longer passive and accepting. The markets are also changing, but I'm really going to skip this. My next slide was to talk about the penetration of the mobile phone, which is becoming the primary access to internet. It is not just for speaking. It's doing a range of other things, and therefore, with the penetration of over 400 million, enabling 250 million people to access internet, this is transformational, and this is growing at a rate of over 32%. So not only do the young kids know Facebook, but if we give them a health record, those same young children are going to find ways, and India's youth will create the knowledge empowerment of healthcare if we can channelize that youth, because they have the power in their phone and they have the power in their hand. So very simply, you understand the technology, you know the markets, you know the greatness of the Indian doctors, but the adequacies. What is our vision? Where are we going? What is the road? Where is the future? And how can technology, collaboration, and partnership give us a framework so that we can graduate from what we're having is a beautiful case of pilotitis in mHealth in India. Everybody has a pilot. Every pilot is working, but there is no connectivity. So here I would really like to, with the permission of everybody here, present a framework which starts at the top to say we need to reach out to touch 1 billion lives. Our division of healthcare, which is the next 3 boxes, should not be public and private. It should be preventive, curative, and emergency. And primary healthcare and secondary healthcare can fall into either of these buckets, because primary care, which may be delivery, needs a preventive aspect and also sometimes needs an emergency aspect. So I'm redefining how we normally look at healthcare to preventive, curative, and emergency care. I put on the right-hand side all the participants of healthcare, whether it's the providers, public and private, the patients, the pharma companies who play a very crucial role in enabling access, the government and the insurance companies, and on the left, all the mediums of connectivity. In the middle is a vision of a healthcare transformation platform with open standards, interoperability, scalable, and with security, taking best of breed from across the world and putting it once into a government-enabled framework that everybody can access, so that we're not individually doing in simple pilots again and again and again, and each of us floundering in our own areas. And therefore, my request, sir, is to find a way that we take tele-advice, the platforms we have, the mHealth, the devices, because people are buying devices like this, glucometers, ECG, autometer, 100 things. None of these devices are going to talk to each other. None of these are going to have a connectivity into the health record. So the next important proposition which I've put in there is that how do we connect, rather than like the United States of America created a compulsion to create the electronic medical record. This became a hospital-based compulsion for data analysis. Because healthcare is moving from the hospital to the clinic to the home and ubiquitous, my proposition is, can we please create a national compulsion for a personal health record? And because disease is very much related to lifestyle disease, we use this personal record to monitor health, to prevent disease which can be prevented, and create a concept of cradle through life. Not to grave, but cradle through life. There's immunization, there's preventive, there's proactiveness, there's analytics. We take the knowledge we have and we put it together with a PHR and a medical response center, which is the call center, because people prefer to speak than to look on the data. So anybody will pick up the phone and say, this is my problem, where should I go? Mera paas ka kaun hospital hai? Kahan jayenge hum? Kitna hoga? Do I have insurance? How much does it cover? Instead, every day, desperate people, first they ignore the disease, then they give wrong medication, then they get onto a bus and go to the largest. So this transformational aspect is detailed a bit, but I'm not going to go through it now because I realize, like I said in the beginning, that I'm standing between you and lunch and the organizers have sent me a slip. But this is detailed on how can India ride through the mobile revolution, use the data and the transformation. Apollo has a few products. The first one we really call HAP, which will be in many individuals' hands from the beginning of next month. HAP is a healthcare app, but it also says if you use HAP, we can give you happiness in your health fail. So these details can also be shared at any time. There's one last big point I want to make, which is the EICU. For the last 7 months, we have been managing over 400 external ICU beds, which are not inside our hospital, using the EICU. This is transformational for the quality of care, which happens in acute patients. I would once again request that we make EICU a standard methodology across clusters in a hub and spoke environment, because there is such a shortage of specialists and critical care. This is the only way we can make that big difference. And finally, I think that it's important for us, as we begin to start creating all these devices, as we begin to start putting together all this information. Mr. Love Verma is here. I want to congratulate the ministry for creating the standard for the electronic health record. From the United States, you will also be happy to hear this. The government bought a national license for SNOMED and built the overall org structure, the data capture structure. You were talking about that of 60 different fields, etc. The data capture structure, the fields, and the standardization platform has been put together in a series of multiple workshops by the central government, so India can have a standardized health record. We must be collaborative. We must work together. We must dream and create a healthier future for our country. And on the base of this standardized health record and the 3 Bs, we will be a healthier country. Thank you all so much, and therefore impact the world.
Thank you, Ms. Reddy.